Imagine walking into treatment for the first time. You may be scared, exhausted, sick, or overwhelmed. You're trying to get help, and someone places a stack of paperwork in front of you. In one of those papers is a consent form. You sign it because you want treatment, but do you really know what you agreed to? Who can receive your information? What they can receive? Can they share it with someone else? And could that information later appear in a courtroom, a custody case, or a probation report? And that is what we are talking about today. I'm Britney, and this is Silence the Stigma, where we talk about addiction, education, harm reduction, and the policies that affect real people's lives. Let's start with informed consent. Informed consent should mean that a person understands what information may be shared, who may receive it, why is it being shared, how long the consent lasts, how to revoke the consent, and what may happen if they refuse. The important word is informed. A signature alone does not prove that someone understood the form. This matters in addiction treatment because people may be signing paperwork while they are in withdrawal, in crisis, afraid of losing custody, or worried about going to jail. That creates an obvious power imbalance. Sometimes a person is technically given a choice, but the choice does not feel voluntary. If someone believes they must sign or lose treatment, freedom, housing, or contact with their children, we need to ask whether they are truly consenting or simply complying. That does not mean every required release is automatically unlawful. It means the person should be told clearly what is required, what is optional, and what information will be shared. Think about how often this happens in real life. A staff member says, "Sign here so we can talk to your caseworker." That sounds simple, but what does talk to actually mean? Does it mean confirming the person is enrolled? Does it include attendance, drug screen results, medication information, treatment plan goals, or counseling notes? Does it allow the caseworker to receive records once or to receive updates for an entire year? Those are very different levels of access, even though they may all be covered by one sentence during intake. True informed consent requires more than pointing to a signature line. The explanation should be given in language the person understands with enough time to ask questions. The person should also receive a copy. Nobody should have to remember the details of a complicated release they signed during one of the most stressful moments of their life. Now let's talk about 42 CFR Part 2, usually called Part 2. Part 2 is a federal confidentiality rule for certain substance use disorder treatment records. It is separate from HIPAA. HIPAA protects health information broadly. Part 2 adds special protections because substance use disorder information can carry serious consequences. It may affect employment, housing, custody, criminal cases, and a person's willingness to seek care. Part 2 generally applies to federally assisted programs that identify themselves as providing substance use disorder diagnosis, treatment, or referrals. This can include many opioid treatment programs, outpatient programs, residential programs, and withdrawal management services. Not every doctor, hospital, or treatment record automatically falls under Part 2. Coverage depends on the program and how the information was created or received. The simplest takeaway is this: substance use disorder treatment is sensitive, and covered programs cannot treat it like ordinary paperwork. Why did the federal government create an extra confidentiality rule for these records? Because stigma has consequences. People have avoided treatment because they feared being arrested, losing a job, losing housing, or having their children taken away. If people believe that everything they say in treatment will automatically be sent to the police, a court, an employer, or a government agency, they might not seek help at all. They may also hold back important information from their counselor or medical provider. That can make treatment less effective and in some situations less safe. Confidentiality is not about helping someone escape accountability. It is about creating a space where people can be honest enough to receive meaningful care. It also protects the treatment relationship. A counselor cannot help someone work through cravings, a return to use, trauma, or fear if the patient believes every honest statement will be reported as evidence against them. The federal government updated Part 2 in 2024, and organizations had to comply with most of the new requirements by February 2026. One major change allows a patient to sign one consent covering future uses and disclosures for treatment, payment, healthcare operations. You may hear this called TPO. This can make care coordination easier. For example, a hospital may need medication information to treat someone safely, but a broader consent also needs a clear explanation. Once Part 2 information is shared for TPO with a HIPAA-covered organization or business associate, that recipient may be allowed to share it again when HIPAA permits. That is why people need to understand how far a TPO consent can reach before signing it. The update did not erase the core protections. The Part 2 records generally cannot be used against a patient in a civil, criminal, administrative, or legislative proceeding unless the patient gives specific written consent or a qualifying court order is obtained. Consent for using records in a legal proceeding must also be separate from consent for other purposes. The updated rule also created protections for what are called SUD counseling notes. Those are notes a clinician keeps separately that analyze the private conversation from a substance use disorder counseling session. They receive additional protection and generally require a separate consent before they can be used or disclosed. Not every progress note qualifies as a SUD counseling note. The definition is specific. Still, the change recognizes an important principle. The private content of a counseling conversation deserves careful protection. The rule also gives patients the right to request certain restrictions and provides rights related to an accounting of disclosures. The details depend on what type of disclosure and how records are maintained. So a person may need help understanding what accounting is available in their situation. The bigger point is that the 2024 update was not simply about making records easier to share. It also meant to align patients' rights, notices, complaints, and breach protections more closely with HIPAA. So what does redisclosure mean? Redisclosure simply means sharing information again. Here is an example. A treatment program sends information to another organization. That is the first disclosure. If the receiving organization sends that information to someone else, that is redisclosure. Under the current rule, not every redisclosure is automatically prohibited. What is allowed depends on the consent, who received the record, the purpose of the disclosure, HIPAA, and Part 2. But one protection remains especially important. Part 2 information generally cannot be used against the patient in a legal or government proceeding without the patient's specific consent or a proper Part 2 court order. Disclosures made with written consent must also include a notice that the records are protected, along with a copy of clear explanation of the consent scope. So in plain language, the receiving person or organization should be told, this information is protected. Do not use or share it outside of what the law and the consent allow. Here is a practical example. Suppose a patient signs a release allowing a treatment program to confirm attendance with a probation officer. The purpose is narrow. The program is supposed to confirm whether the person attended. That does not automatically authorize the program to send the person's complete assessment, trauma history, medication record, and every counseling note. It also does not automatically mean that information can be copied into an unrelated report or used for a different purpose. The consent matters. The recipient matters. The purpose matters. This is why the phrase, I signed a release, does not answer every privacy question. We still need to know what the release actually authorized. Hospitals show why this issue can become confusing. There are valid reasons for sharing treatment information. An emergency room doctor may need to know that a patient takes methadone or buprenorphine. That information could prevent a medication interaction or help the hospital avoid interrupting treatment. The concern is not appropriate care coordination. The concern is whether the patient understands who may see the information after it enters a larger health system. Shared electronic records may be available to clinicians, pharmacies, billing staff, and affiliated providers when access is permitted for their work. Before a person signs a broad TPO consent, the program should explain what treatment, payment, and healthcare operations mean in everyday language. People should not have to understand legal abbreviations to understand their legal privacy choices. There is another side to this conversation that deserves attention. Keeping information too restricted can also create harm. If a hospital does not know a person receives methadone, it may fail to continue the medication, misunderstand withdrawal symptoms, or make unsafe assumptions about pain treatment. If an outside provider cannot confirm a medication dose, the patient may experience delays or unnecessary distress. So the answer is not to stop all information sharing. The answer is purposeful sharing. Share what is needed for safe care, explain the consent, limit access appropriately, protect the information from being used for unrelated purposes. Privacy and care coordination do not have to work against each other. A well-designed system can do both. Now let's talk about children's services. This is one of the highest stakes situations because a parent may believe that refusing a release could affect custody or visitation. A caseworker may need certain information to evaluate safety or confirm that a parent is following a case plan. But confirming treatment participation is not the same as releasing an entire clinical record. There is a difference between sharing the parent attended treatment this month and sharing detailed counseling notes, trauma history, diagnosis, medication changes, drug screen results, or every setback discussed in treatment. The release should match the actual need. It should identify what may be shared with whom and for what purpose. One important exception also needs to be clear. Part 2 does not prevent a program from making a report of suspected child abuse or neglect when the state law requires it. However, that exception does not automatically open the patient's full treatment record for a later custody or court proceeding. The goal should be enough information to address the legitimate concern, not unlimited access to a parent's recovery story. This is especially important when people misunderstand what recovery looks like. A treatment record may show that a parent reported cravings, missed an appointment, needed a medication adjustment, or experienced a return to use. Those facts may need clinical attention, but without context, they can be misrepresented as proof that treatment is failing or the parent does not care. Recovery is not measured by whether a record looks perfect. Honesty about a struggle can actually show engagement. Asking for help after a setback can show insight. Agreeing to a higher level of care can show responsibility. When detailed clinical information moves into a custody system, the person reading it may not understand those distinctions. That is another reason to define the purpose of a release and share only the information reasonably connected to that purpose. Parents should also understand that refusing or limiting a release may have consequences within a case plan or court process. Even when the treatment provider itself cannot condition treatment on certain optional disclosures, they deserve an honest explanation of those consequences, not a promise that saying no will never matter. Treatment may also be connected to probation or parole. A supervision officer may need to know whether someone enrolled, attended, or completed a required program. That does not automatically mean the officer needs every clinical detail. Attendance is different from session content. A drug screen result is different from a counselor's full progress note. A treatment recommendation is different from a person's complete story. When treatment is required as part of criminal justice supervision, Part 2 has special consent rules. The consent may last until a specific event, such as the end of supervision, and it may not always be revocable during that period. That makes a clear explanation even more important. Before signing, the person should understand exactly who will receive the information, what information will be sent, how the information may be used, when the consent ends, and whether it can be revoked before then. Accountability does not require unlimited access to therapy conversations. Imagine a person tells a counselor, "I had a terrible week. I wanted to use, but I called my sponsor and went home." Clinically, that may be evidence the person recognized a trigger and used a coping skill. But if only part of that conversation is repeated, such as the person wanted to use, it can sound like evidence of instability. Context matters. This is why programs should distinguish between information needed for supervision and information needed for treatment. Probation may need to know whether the person is following a court order. The counselor needs a private space to help the person discuss thoughts, fears, and setbacks that could affect recovery. When those roles blur together, patients may stop being honest. That does not make the community safer. It makes it harder for providers to identify risk before a crisis occurs. Recovery courts and drug courts bring treatment and the legal system together. These programs can provide treatment, structure, support, and an alternative to incarceration. They also involve regular information sharing among several people, which may include the judge, probation, treatment providers, the prosecutor, the defense counsel, court staff, or case managers. Participants may be asked to sign releases as a condition of entering the program. That does not mean every person on the court team needs the entire clinical file. The team may need information about attendance, general progress, drug screen results, or compliance with court requirements. Counseling notes and unrelated clinical details are a different matter. Part 2 places strong limits on protected treatment records against a patient in legal proceedings. A normal subpoena alone may not be enough. Depending on the situation, specific consent or a special Part 2 court order may be required. The safest and most respectful approach is to decide in advance what the court truly needs, who needs to receive it, how it will be reported, and what will remain private. Participants should hear the explanation before signing, not after information has already been shared. Recovery courts also need to think carefully about team meetings or staffing sessions. Information can spread quickly when many professionals are in the room. One person may believe a detail is important for treatment. Another may view the same detail as non-compliant. Someone else may reclude it in a report. The team should have written boundaries about what treatment providers report and how the information may be used. For example, a court update could focus on attendance, participation, general progress, current recommendations, and immediate safety concerns without repeating every private statement made during counseling. This protects the participant, but it also protects the integrity of the court program. People are more likely to engage honestly when they know the boundaries. Providers are more likely to report consistently when expectations are clear. Judges receive information that is relevant instead of being overwhelmed with clinical details that may easily be understood. Treatment court works best when treatment remains treatment, even when the court maintains appropriate accountability. Good consent is specific, understandable, and limited to the actual purpose. Before signing, a person should be able to answer 6 questions. Who will receive my information? What information will they receive? Why do they need it? How may they use it or share it? When does this consent end? Can I revoke it, and what happens if I do? If the person cannot answer those questions, the form has not been explained well enough. Programs should avoid using one broad phrase like treatment team when several agencies or legal professionals may receive the information. Plain language builds trust. Clear limits build trust. Sharing only what is necessary builds trust. And trust makes people more willing to be honest and stay engaged in treatment. Good consent should also be reviewed over time. A person's situation may change. They may get a new probation officer, leave a recovery court, close a children's service case, change treatment providers, or decide that a family member should no longer receive updates. A consent form should not disappear into the chart and remain forgotten. Programs should know when it expires. Patients should know how to ask whether it is still active. If a consent no longer serves its original purpose, it should not continue simply because nobody reviewed it. This is especially important when the consent names a broad category of recipients instead of one specific person. The legal requirements can vary depending on the type of consent, but the ethical practice is simple. Keep the patient informed about where their information is going. So what can you do before signing? If someone hands you a consent form, you do not have to pretend you understand it. You can slow the process down and ask questions. Start with the name of the recipient. Ask, is this going to one specific person, one agency, or an entire group of people? Then ask, what information is included? If the form says all records, ask whether the release can be limited to attendance, medication verification, or drug testing results, or another specific category, whatever you choose. Ask about the purpose. Is this being shared for treatment, payment, court monitoring, a custody case, or something else? Ask when the consent ends, guilty program. Finally, ask for a copy of the signed form. Keep it with your other important records. If questions come up later, you will be able to see what you actually authorize. If you believe your information was shared improperly, you can start by asking the program's privacy contact or Part 2 contact for explanation. You can ask, what information was disclosed? When was it disclosed? Who received it? What consent or legal authority allowed the disclosure? Depending on the circumstances, a person may also be able to file a complaint with the program or with the U.S. Department of Health and Human Service Office of Civil Rights. If the information is connected to a criminal case, custody matter, or other legal proceeding, speaking with a qualified attorney or legal aid organization may be important. The purpose of asking questions is not to create conflict. It is to understand what happened and protect your rights moving forward. Here is the main point I want you to remember. Asking questions about a consent form is not being difficult. It is not being paranoid. It is part of informed consent. You can ask, who will receive this? What exactly are you sending? Will they be allowed to share it again? Can this be used in court? When does the consent expire? Can I receive a copy? You deserve clear answers before your information leaves the treatment program or any other agency. Privacy is not about hiding recovery. It is about making sure people can seek help without giving every system unlimited access to the most personal parts of their lives. I'm Britney, and this is Silence the Stigma. Keep asking questions, keep protecting dignity, and keep changing the conversation.